Good evening. I'm Dr. Daryl Cass, Vice Chair of APSA's Fetal Diagnosis and Therapy Committee. On behalf of our Chair, Dr. Ronnie Marwin, and our entire committee, I'm pleased to welcome you to Session 2 of our committee's APSASodes. In Session 1, we heard discussions from several abstracts. In addition, we reviewed the biology and scientific rationale of FETO and talked about some of the technical aspects of FETO balloon placement and reversal. Tonight, we're going to delve deeper. We're going to begin by a lecture from Dr. Jan de Prest, someone who needs no introduction. Jan is the lead author from the 2 recently published randomized controlled trials examining the role of FETO in the treatment of fetuses with diaphragmatic hernia. Following this presentation, we're going to have a live debate, which will include Dr. Kevin Lowley, David Cates, Francois Lukes, Olyinka Olatoya, and others. And finally, we're going to have a live question and answer session in which members of the panel will be able to answer questions from you all and from each other. I hope you enjoyed tonight's session.
Dear friends, thank you for allowing me to present the long-awaited results of the total trial. This trial was conducted in 15 countries, over 13 fetal surgery centers, and 46 neonatal centers. Today, diaphragmatic hernia should be diagnosed in the prenatal period thanks to screening programs. This is clinically the case in 2 out of 3 cases in the second trimester. First trimester diagnosis is also possible, but much less likely. Once the diagnosis has been made, the patient should be transferred to a center with a higher level of expertise for comprehensive assessment and multidisciplinary counseling by physicians who are used to manage those patients. Also there, arrangements for timed delivery needed to be made, and in the future, as you will see, also a proper assessment and prediction will need to be offered so that prenatal management can be discussed. In those centers, first, an effort will be done to rule out associated structural and genetic problems. In isolated cases, the severity of the condition can be measured by measuring the lung size, and this can be done by 2-dimensional ultrasound. On a 4-chamber view, the contralateral lung can be measured. It will be expressed as a function of the head circumference and corrected for gestational age. The observed over expected lung-to-head ratio is a percentage of the normal. In addition, the position of the liver can be determined by ultrasound as being either in the chest or confined to the abdomen. In Europe, there is a standardized assessment method that now is used by the reference network for managing patients with diaphragmatic hernia. Throughout the trial, patients were counseled based on this lung-to-head ratio as well as on the liver position. In fetuses with a lung-to-head ratio over 35% with the liver into the abdomen or higher, these patients were considered as having mild hypoplasia because their expected survival rate is extremely high. In fetuses with moderate hypoplasia, those are fetuses with a lung-to-head ratio between 25 and 45%, in the latter category, fetuses who have liver herniation. In those, the expected survival rate is around 40 to 50%. Fetuses having lung sizes under 25% were considered as being severely hypoplastic, and their expected survival rate is under 20%. This was the initial target group for fetal therapy. Fetal therapy has a long history. Initially, anatomical repair was attempted. It was technically feasible but could not be offered to fetuses with liver herniation. Therefore, alternatives were looked at, and it was J. Wilson who proposed to use tracheal occlusion as a method to stimulate lung growth. Our group has contributed to this odyssey by proposing a fetoscopic technique that can be done percutaneously and using an endoluminal balloon. In the early 2000s, tracheal occlusion was already clinically applied in Philadelphia as well as in San Francisco by open hysterotomy or fetal tracheoscopy. We in Europe embarked on a technique purely percutaneous and fetoscopic, and in a review of our initial experience in around 200 patients, it was suggested that survival would be increased by FETO as compared to expected management, although that was of course compared to historical data. Therefore, randomized data were required. During the total trial, we also published a study on the maternal safety of fetal tracheal occlusion, demonstrating that also the reproductive potential of those patients was not compromised. When designing the total trial, we were trying to overcome the main limitation of fetal surgery, and that is premature delivery. And in diaphragmatic hernia, prematurity is a real additional problem next to pulmonary hypoplasia, as you can see on this plot, where survival is clearly dependent on gestational age at birth. When performing fetal tracheal occlusion, delivery can be premature, and in this study it was clear that when babies were born beyond 32 weeks, they had the highest chances to survive, and for that reason tracheal occlusion was in the severe group offered between 27 and 30 weeks, but in the moderate group, which was a new target population, the balloon was inserted between 30 and 32 weeks to avoid at any price a delivery earlier than 32 weeks. In this trial, we hypothesized that tracheal occlusion, as compared to standardized expected management and standardized postnatal therapy, would increase survival. Severity was defined by the lung-to-head ratio and position of the liver. In this trial, the primary outcome was survival to discharge from the neonatal intensive care unit, and in the moderate hypoplasia group, a co-primary outcome variable was taken into account, which was oxygen independency at 6 months of age. This was a trial with a sequential design with 5 pre-planned interim analyses so that the trial could be stopped as early as possible when one or the other therapy would show benefit. The trial was also designed such that all patients would be assessed at the fetal surgery centers, that following assessment, patients could be either randomized to expected management, and that management could be done at the initial referring center. For those randomized to fetal surgery, the balloon was inserted either at 27 to 29 weeks for severe cases or at 30 to 32 weeks in the more moderate cases. Balloon would be removed at 34 weeks to stimulate lung growth or earlier in case of clinical need. Once the balloon was removed, again patients were allowed to be referred back to their postnatal management centers. The technique was a fetoscopic technique under local anesthesia with fetal immobilization and pain medication using instruments of 3.3 millimeter. Also, the balloon was a standard balloon that is borrowed from interventional radiology and used off-label. There were in- and exclusion criteria for fetal surgery, the main exclusion criteria being maternal risk factors, a risk for preterm birth, psychosocial factors, or non-compliance. For the fetal surgery centers, they were required to have an active fetoscopy program. This was empirically defined as 36 cases per year, and they would have done 15 procedures prior to their first randomized patient. Obviously, also these centers should be experienced with the antenatal assessment and management of fetuses with congenital diaphragmatic hernia. In the video animation, one can see how this technique is a completely percutaneous technique and nothing more than a fetoscopic intubation. The balloon was removed either by ultrasound-guided puncture, by fetoscopy, or under fetal immobilization and pain relief during a standard cesarean section while the baby was still on placental circulation. Once the balloon was removed successfully, the cord could be clamped. In an emergency, postnatal puncture was also permitted. All babies were managed in a standardized way according to this protocol. In the severe trial, 95 patients were randomized in total. An interim analysis was done at twice 40 patients, whereas the other patients that were recruited between the 40th patient and the time point the analysis was conducted, these patients are called the overrunning patients. We will present in this talk the twice 40 patients that were analyzed on an intention to treat basis. However, the outcomes with overrunning patients were completely similar. In the moderate trial, 196 patients were randomized, which was the entire calculated cohort. Twice 98 patients, 5 interim analyses were done, and again, here we will present on an intention to treat basis the data of all the patients that were included. The baseline characteristics are comparable in the severe trial in red and in blue for the moderate trial. These color codes will be respected throughout the further presentation. One can see here also the characteristics of the severity of hypoplasia, and again no difference in amniotic fluid volume, which was judged to be a potential predictor of prematurity. Same for cervical length, and here you see comparable statistics for placental location. In the severe trial, the primary outcome was survival at discharge, and this was significantly higher in the patients that were managed in the antenatal period. This difference persisted until 6 months of age. There was a slight difference in survival without oxygen need. This trial was only powered for the primary outcome variable, so no statistics were done for the secondary outcomes. Fetal surgery significantly increases the risk for membrane rupture and as a consequence for premature delivery. In 4 out of 10 cases in the severe trial, delivery was before 34 weeks, which was not the case in the expectantly managed group. As a consequence, the birth weight was lower, and below one can see the difference in a number of neonatal outcome measures. Again, this trial was only powered for to measure differences in survival from NICU, so no statistics were attempted for all these secondary outcome variables. We think there is not really a obvious difference in these secondary neonatal outcomes. In the moderate trial, where there was a co-primary outcome at 6 months of age, survival till discharge after FETO was 63%, whereas expectant management was associated with a survival of around 50%. This did not reach significance. The confidence interval was 0.99 till 1.63. Same trends at 6 months of age in terms of survival, and here even smaller differences in oxygen dependency. The neonatal outcomes in the severe, as well as in the moderate trial, here in blue, are displayed on this slide, but there were no obvious specific trends when one looks at these outcomes. Safety analysis demonstrated problems which were uncommon with trocar insertion, bleeding at the entry point, in one case leading to the need for delivery, and that was at the time of balloon removal. Then balloon removal problems in 2 patients, which I will discuss in a second. This was clinically extremely problematic. In one case, it took up to 2 minutes to remove the balloon, but the patient had a normal pH. There were 2 cases of obvious tracheomalacia. In one other case, this was an incidental finding. In terms of technique, in one case, the surgeon failed to access the mouth and no balloon could be placed. There were spontaneous balloon deflations and/or displacements in 6% of cases over both trials. One should keep in mind that we are using off-label a vascular occlusion balloon, which has in the past also been reported to potentially deflate and displace. In terms of removal problems, again, there were 2 problems. In one patient in whom the balloon was retrieved in an emergency, resuscitation failed, and at necropsy the balloon was found in the trachea. In retrospect, a direct visualization technique was used by the fetoscopist, and unfortunately the physician judged the balloon was removed, but it was not. In one other patient who was not compliant, she moved away from the fetal surgery, presented in labor at 32 weeks, and unfortunately the balloon could not be removed. Below one can see how the balloons were removed. In the majority of cases this was by fetoscopy. The other techniques were less commonly used. This trial has several strengths. It's, to our knowledge, the largest trial in fetal surgery ever. We were able to recruit a relatively large number of patients for a rare condition. It was possible to offer this at several sites in a standardized way, and the outcomes that were observed are very much in line with earlier studies from the same operators, and no data were missing for the primary outcome variables and virtually none for the secondary outcomes. Weaknesses of this trial was its long duration, more than a decade. Centers were not blinded to treatment groups. The design was unstratified for fetal surgery centers, and we lack medium and long-term outcomes. Uncommon complications may not be well documented with this still relatively small number of procedures. And obviously the outcomes that were observed in this trial cannot be simply extrapolated to the experience of other centers that may have another case mix, or on the other hand may not have the same expertise with prenatal assessment or prenatal management. This trial was also disturbed by the presence of backdoors and a lot of controversy, in particularly in the last year of the trial. The trial also shows that at this moment there is a lack of a core outcome set for this condition that we should use for perinatal management studies. So in conclusion, in severe congenital diaphragmatic hernia, there is a significant increase in survival by fetal surgery. This applies to left-sided cases as well as to right-sided cases. However, a different cutoff needs to be used for defining the degree of hypoplasia. In moderate diaphragmatic hernia, the effects of fetal surgery are much less prominent and were not significant. FETO is associated with a very high risk for membrane rupture and, as a consequence, preterm delivery. The maternal risks seem very limited, but balloon removal problems can be lethal for the neonate. At present, the long-term outcome of this prenatal surgery is not well documented. We are at present analyzing the pooled data of both total trials to define the impact of the duration of occlusion, because as you know, the duration of occlusion was significantly different between both severity groups. We think that in the future, the invasiveness of this procedure may be less by using smaller instruments or, for instance, a balloon that can be reversed externally, so without the need for a second procedure. Lastly, we think that the findings of this study may not be simply extrapolated to other centers who may have a different case mix, different background survival rates, or have less experience with fetal surgery. I thank you for your attention. I thank all the sponsors for our experimental and clinical program.
It's a great pleasure to comment on this, and I'm David Kays from Johns Hopkins All Children's Hospital. Today we're going to discuss, with response to that, whether to FETO or not. I want to congratulate Jan and the team for these amazing articles about severe and moderate use of FETO in severe and moderate CDH disease, and that creates huge visibility for FETO. As we know, 40% survival in the FETO group for the severe disease and 63% survival in the moderate. But of note, the preterm delivery incidence was 75% in the FETO group, in the severe group, with fully 25% delivering before 32 weeks of gestation. I want to remind us that we're all focused on improving CDH outcomes. We're all on the same team. Some of us have focused on prenatal interventions and some have focused on postnatal interventions. And my particular focus and our team has been on postnatal interventions, including better ventilation, better ECMO, better surgery, and hopefully better decision-making. To comment on the paper, in the severe group, the background survival was 15%, which I felt was surprisingly low. And the use of ECMO in the severe group, in the expectant care group of the severe group, even though 85% of patients died, only 29% received ECMO support. And in the FETO group, even though 60% died, only 5% received ECMO support. For the moderate group, the background survival was 50%, and the ECMO use in the expectant group was 20%, even though the mortality was 50%. And in the FETO group, mortality was 37%, but again, ECMO use was low at 21%. Now, whether to treat severe patients with ECMO and what the benefits are, we addressed in a paper that we published in 2015 when we tried to find the 10% physiologically most severe patients in our group. And we had treated 170 patients, and here are 17 of them, the worst 10% that we found. And we found that if we treated them aggressively, that indeed about 50% of them could survive. We also found that of the ones that didn't survive, 3 of them were premature. And so the combination of severe CDH and prematurity can be a very difficult one. And none of these premature babies in our most severe group survived. Now, I also noted in the CDH FETO study that CDH repair didn't occur in all of the patients, that in the severe group, the mortality was 85% in those treated expectantly, but the non-repair rate was 63%. In the FETO group, mortality was 60%, but the non-repair rate was 47%. In the moderate group, the mortality was 50% with a non-repair rate of 26%. And in the FETO group, the mortality was 60%. This is not correct. Mortality was not this, but the non-repair rate was, I believe the mortality was 37% and the non-repair rate was 16%. That goes to treatment, CDH treatment fundamental that we practice, which is repair of the hernia. This is data from the University of Florida, and you can see in the patients that came to repair, the survival rate was much higher than those who were not repaired. So in evaluating these papers, we note that a large percentage of patients were not treated aggressively if we use ECMO as a criterion for aggressive treatment, and a significant percentage of patients also didn't get repaired. So these studies appear to be comparisons of FETO versus what I would call a non-aggressive CDH management. This served to highlight the beneficial effects of FETO, but in this environment, FETO was beneficial for severe disease. But is that the current standard? I look forward to see what Dr. Lally has to say about what the CDH study group might show us about this. Now, for those of us who have been focusing on postnatal management, if we work to improve background survival, what if the background survival, rather than being 15% in the severe disease group, had been 50% or 60% or 70%, 75% or even higher? Would FETO still have shown significantly improved survival? And at what level of background survival would FETO have been a negative effector of survival due to technical issues, as we saw a couple of babies have difficulties, and from the risk of prematurity? Now, I can't comment on what the standards of care are around the country, but I can report on the care fundamentals at our center. We practice really strict protective lung protection, inclusive use of ECMO in severe disease, timely repair of CDH in all patients, delivery of better ECMO, and highly consistent care. Focusing on postnatal management, since we started this management at Johns Hopkins All Children's, we've cared for over 180 consecutive patients, and survival for moderate disease is over 90%, and survival for severe disease, interestingly, is also over 90%. So in the background of greatly improved postnatal management, at least with regard to survival, the role of FETO seems small. Those are my comments. Thank you for the opportunity to speak.
Thank you for the opportunity to respond, and indeed, Dr. Case, when a trial like this would be designed against a background of survival rates that are related to severity assessments, I cannot really tell that for your center with such high survival rates, whether there is any predictor for those not doing well, that means not surviving, or for those that would survive with certain morbidities. So that would be already very difficult to do so if the background survival is so high. So therefore, it is perfectly possible that whatever we observe in this trial would not be applicable to your population or your center's outcomes. We can only see in the trial that we have performed, we obviously critically looked at what the background survival rates were that we used for designing the trial. And surprisingly or not, the survival rates that were predicted based on the severity assessment methods we used, actually 15 years later proved to be still true with the current management methods and the postnatal management. So what we predicted to be the survival also materialized in the trial. And that was not necessarily what everybody expected, but that is what happened. You can also, of course, look whether there would have been a certain bias. We looked also at outcomes in the patients that were judged to be eligible, but that did not participate in the trial. And there, I'm sure you have read it in the supplemental information, we have given outcomes in those expectantly managed. And some patients really also had FETO because, as you know, the trial was not watertight in terms of having access to the fetal therapy. Well, there are some differences, but unfortunately the population differences between those randomized and not randomized make it impossible to make a true comparison. Because in the non-randomized patients, we didn't keep track of structural or chromosomal anomalies. We didn't take into account preterm prematurities, terminations of pregnancy. And actually, when we had a look at the severity of the condition in the patients not randomized, even that was not comparable. So that comparison doesn't really help us. We conclude from the numbers that we have observed in this trial that the current prediction model that was used is still usable in the setting of the centers that participated in this trial. So that is in a way an answer to both questions, is that what is the standard of care and what should be the expected outcome be with postnatal management? Well, for the centers that were part of this trial, we apparently, with the current standard of care, have lower survival rates than what you described. Whether then there is still a place for FETO in your population, that's of course very questionable, and you would have to design a trial that focuses at other goals. And this brings me to answering your first question. If you would ever consider offering fetal therapy for the fraction of the population that is either having severe morbidities or will not survive, you will have to accept the side effect that inevitably will be there, that of FETO, that is prematurity, being born at a weight where that makes the management so much more difficult. So I'm sure that you would come up with a nearly unrealistic design of a trial, because your numbers would need to be that high to even investigate the question. And it's actually very unlikely that if your survival rates are so high that in your population, FETO would have a very specific place unless we make it much more powerful or not causing prematurity. And the answer to that is known. It does cause prematurity.
Thanks, Jan, for that. And I think that this is a perfect segue, but maybe is then, are we changing the pulmonary vascular tree response enough to say we are using less and less ECMO? So I'm thrilled to have Dr. Lally kind of give us the CDH registry perspective on, what is the data out there in terms of the outcomes here in the non-FETO centers.
Thanks, Roni. Jan and I have had these conversations over about 15 years, and I think 3 or 4 continents. And when the trial was concluded, I was as happy as anyone. Being a trialist, this was an enormously complicated, difficult trial to achieve, and it took an incredibly long period of time, which many of these types of trials do. Having said that, I have a little bit of a truth in advertising. We were the only US center that participated in the severe arm of the trial. And I do want to talk about the other 2 trials, randomized trials, one being the Brazil trial, and in truth in advertising, Dr. Urano was on our faculty as well. So, so we have a little bit of a bias there. However, if we look at the trials, they've all
been a change in bias.
well,
right? Evolution.
Keep an open mind, but and I kind of fall in between some of these here. But if you look at all the trials, they suffered from the same problem, including the FETO, and that was basing their sample size estimate on historical controls, and the historical controls in the original paper by Jan and Dr. Gani was in the extreme high risk group was even lower than 15%. And we've never been able to find those patients in the registry. Same thing occurred with the Brazil trial. The survival rate was incredibly low in the control group. And the Harrison trial that got stopped also used historical controls to base their sample size. So all of these trials have suffered from using backstory, if you will, controls versus contemporary outcomes. And what I appreciate what Yuan is talking about in terms of the survival rates kind of held true, they're not entirely what we're seeing. However, if you had to just pick a point estimate and say, is there benefit or not, the literature data says that there is benefit to FETO, but where it might fall in the scheme of things, to me, is an enormous open question. And also we have to keep in the focus that if we're talking about the patients in the severe trial, which is what I'm mostly commenting on, and we just looked at the numbers, there's at most about 100 or so patients in the entire United States that would be FETO candidates in any given year. And that's if you embarked on doing FETO in every single candidate that's possible. That's a complete other risk that we have to recognize, because when the MOM trial came out, there was an explosion of centers doing fetal myelomeningeal repair without the background or expertise to do that. And I think most of us would have a serious concern about some centers embarking on this without having the expertise to actually do it. That's always a risk when you demonstrate a trial with a new technology. So having said that, then if we look at the and I appreciate David's focus on this over so many years. It's a great example. Everybody on this call has really been interested in this problem for a long time, and that consistent focus on care has led to some incredibly good outcomes. He's correct in terms of in my opinion, some of the analysis of these trials. I am concerned in just evaluating the trial that the non-operative rate was extremely high. If we look at across the board for the entire registry, which does represent 18 different countries, this is an international registry, and the non-operative rate on average is around 18%. And if you look at those centers that take an aggressive approach to management, which we have historically done here in Houston, it's around 5 to 6%. Our own non-operative rates are around 6%. It is a self-fulfilling prophecy that if you don't operate on diaphragmatic hernia, they die. And of concern in the trial is that there's a much higher non-operative rate in the expectant management group. And you worry about a treatment effect here in the sense of that we're going to try a little harder on the FETO patients and the other ones that we're not going to try hard. I would have that level of concern. Now we look specifically, what I was tasked to do is the specific CDH study group data comparing apples to apples. And when we look at those patients who have a O to E LHR less than 25% with liver up, which is, I believe, 90% of the patients in the trial. Survival of those patients without major anomalies was 39% across the board. So CDH registry survival is substantially higher than what we saw in the FETO group, in the very select group of patients that we're talking about that are eligible for, that would have been eligible for the FETO trial. So, so where does this kind of all settle out? And certainly in an institution like mine, where we have ongoing conversations around these issues, we did participate in the trial. We didn't submit a lot of patients to the trial, and survival from our patients was the same in the expectant and the FETO group. So in our part of that study, we're not honestly 100% sure. We have ongoing conversations. There may be a role in a small subgroup of patients that we have not fully identified. We believe that if a patient comes to our fetal center, that we, in the extreme high risk group, that we should at least embark on a conversation about optimal therapies. We do try and present both arms of this. Tony Johnson on our fetal group and Matt Harding, who heads our postnatal management team. Kind of, it's a joint conversation with families. So, however, my own personal biases, if it does have a role, it's going to be a very small role. And the number of patients in, as I say, in the entire country is realistically very small. But again, Jan, congratulations, because I know how incredibly difficult these trials are.
Thanks, Dr. Lally. Jan, any comments?
I first would like to thank Kevin. I do remember the first time I was allowed to present the prediction model in Houston. I mean, he kept me alive because he was now very elegant in his argumentation. The style was a little bit more Texan that day. I remember 15 years ago. Anyway, number one.
I remember it clearly.
So severe is uncommon, that is without any doubt, and this was also one of the reasons why it took us so long to recruit so many patients. In our initial registry, it was under 15% of the population we've seen, and that continues to be so. So that only shows how difficult it is to gather a sufficient population and then in a sufficient short time, because that's the second thing that you actually question is, what is the natural history of babies with severe CDH, the way we define it? Because you take then data from the CDH registry, and what you actually do is you compare the outcomes there in those not treated prenatally to what we have observed before the trial, and as I said, also during the trial. And there is a mismatch. I mean, there is an apparently higher survival rate across all your participating centers. I can only say our data, they could not be more unbiased, because these patients were part of the trial. The selection criteria were very strict. I mean, the people who have selected these patients have been using the same methods. They all had experience with the methods, and this is what we observe. And again, it is certainly possible that the data that end up in the registry are biased in a way that, for instance, that is more in babies that did survive and that ended up in the registry, that a few terminations, other anomalies were not in. I mean, as you remember, also, you have seen there is a worrying high number of babies that had associated anomalies, although we thought they did not have. And not only genetic problems, but even structural problems. So when you start to register from postnatal, I mean, that's all possible biases that can be in there. And I can, of course, only look at the unbiased population of the total trial. The non-operation rate, this is, of course, the hardest thing for me to speak about in a pediatric surgical meeting, not being even involved neither in the decision when and how to operate these babies, or, as you said, not to operate on these babies. It is certainly possible that this reflects let's say an attitude in those participating centers, whether they proceed with therapy postnatally and where they actually do not proceed to an operation because they don't think the baby is appropriate for that. The only criticism that I think we as the PI of the trial is, of course, this is really a limitation. We were obviously not blinded to the arm that the patient was assigned with, but I have no idea in what way we could have countered that. And I am very, I actually trust that this has not really been the case, that we tried harder on the treatment arm as compared to the others. I mean, because we followed the same protocol, there were so many centers involved that it cannot have been a complot to try to make this trial work by giving different chances to these babies. That's the only reflection I can have, and I really would doubt that this has been the case, but it is definitely a limitation of this trial. I hope, Kevin, you don't remember me only because for having had the courage to do the trial, but that it was a little bit more than that, and that we have learned really something biologically from this trial as well.
Great, thanks, Jan.
Congratulations to Jan for this incredible endeavor, and also a disclaimer. In fact, I am a co-author on that paper. Then again, I'm not alone. I think Jan is a very generous person. There are more than 2,000 authors on that paper. So again, in very good company. So the trial, we've heard some of the possible limitations of the trial. I think some of the hurdles include the fact that it is still in 2021 difficult to stratify the exact severity of diaphragmatic hernia. We haven't talked a lot about that yet, but clearly we had a great breakthrough decades ago with LHR, and then we had obviously what's been used here, observed or over expected LHR. We can look at lung volume, calculated in any which way. So we still, despite the fact that we call this severe versus moderate versus very severe, it's still not always easy to stratify it, especially across centers and definitely not across continents. We heard from Dr. Kays about the best possible outcome in postnatal treatment, but one of the flaws, the recognized flaws of the trial, is that there was a lot of heterogeneity in the way patients were treated postnatally. So that, of course, that then makes it much more difficult to evaluate the trial at its true value. I think Dr. Marwan touched on that as well. What do we call success? Do we call it lung growth in utero? That's almost universal with tracheal occlusion, and certainly decades of experimentation proved that was the case. But we also know, and unfortunately, I'm one who's seen this happen. Patients with prenatal treatment with fetal tracheal occlusion, a great outcome in terms of lung growth, survival at birth, survival at 30 days, but died on ECMO at 34 days. So those things do happen. So what do we call success? We definitely need to look at a composite of morbidity and mortality, look at outcomes at 6 months and beyond, which to your credit, you did in that trial. But when you look at the difference between the patients in the FETO arm and the expectant arm, the NICU days, ventilation days, the number of patients with pulmonary hypertension was not very different between the two groups. So it's certainly not a perfect situation. And then the biggest elephant in the room, at least in the United States, is we don't have a balloon. We don't have a device. So the FDA plays a huge role that we need to address as well. All this said, what is the downside of fetal surgery for diaphragmatic hernia? And to kind of paraphrase, or at least to continue Dr. Kays' idea, what if the approach was really minimally invasive and incredibly safe, and other than some discomfort was, again, minimally invasive for the mother, that the level of prematurity, which was seen go down over the decades in terms of fetal intervention, what if we brought it down to a minimal number? What if it really could eliminate the need for ECMO? What if it could decrease tremendously the cost to the NICU? All those things, again, as we're if we're going to just play the what if game, we can do that as well for fetal intervention. It's certainly feasible. It's not now. So the answer is, the question is not, is it perfect now, but are we on a path where maybe 10 years from now, 20 years from now, fetal intervention really will be minimally invasive? Would it then make sense? What would be the downside of fetal surgery? I think that's, I can't remember, somebody brought up, I think Kevin brought up the MOMS trial. Maybe we should look at that. When you think about it, other than a lot of us being very nervous about any center starting to do a prenatal repair of myelomeningocele, it was pretty much accepted very quickly that, yes, it made perfect sense to repair a myelomeningocele in utero because it was better than doing it postnatally. When you think about it, it's not a lethal condition. It's not even, it's certainly much more invasive other than the few centers that do it endoscopically. It's still an open fetal operation, which is pretty morbid for the mother, never mind the pregnancy and the fetus. It's also one where, when it works perfectly, still does not allow the majority of patients to walk at 30 days, 30 months. So the indications, the stakes are much, much lower in repair of myelomeningocele than it is that they are for diaphragmatic hernia, and the risks of the mother and the fetus are actually higher. So again, I think those are important points to consider in my mind. And then speaking of the MOMS trial, the FDA issue for the device, because that's still a big hurdle, at least in the US, we are not only held hostage by the FDA, but also by the industry, because there's really no market, as Dr. Lally said. We're not talking about a lot of patients who will be candidates for fetal surgery for diaphragmatic hernia. So how do we get a company to make, a handful of devices? That's really not feasible. Well, the MMC, though, the Fetal MMC Consortium, was able to rally and to convince the industry to help us out and to provide us with absorbable staplers, even though they pretty much stopped manufacturing them for any other indication. So I think we have some lobbying to do, and that's an important point. And then finally, what are the next goals in my mind, other than to incrementally continue to make fetal intervention safer, fewer complications, fewer incidences of prematurity? The two next steps in my mind are having to reoperate to retrieve the balloon is probably too much. Yes, it works, but if one fetal operation is a big endeavor, two within less than 2 months is, I think, that's a problem. So we need to find a better way to retrieve the balloon, or to stop if the future will be a balloon, to stop the occlusion. And then we also need to have an emergency switch. We need to be able to deflate the balloon at will, or deflate or reverse the occlusion at will in case of, for example, a premature rupture or onset of labor and things like that. And I know that Jan and other people are working on newer, better devices. But so in general, I don't think that the question is, should we do it or should we not do it? I think the better question is, are we on the right path? Can we, with improvements, can we see a role for fetal surgery for the diaphragmatic hernia in the future once we solve some of those problems? So I'll stop here.
Great, thanks, Francois. So what is the future, Dr. Latoya? What do you think? Are we at a point where we reach a critical mass, so to speak, from a research perspective, and a reversible tracheal occlusion that we don't have to do a second procedure for? And is it time to start thinking about, how do we not only grow the lungs, but how do we modulate the pulmonary vascular tree to a point where, the ROI on a fetal procedure, yes, with prematurity and rupture of membranes is acceptable because the gain is so much more?
Yes, thanks for the opportunity to be part of the discussion here. I'm being called to, I'm at Nationwide Children's Hospital right now, but as a disclosure too, I was previously at Baylor College of Medicine, Texas student, and we were part of that institution was part of the moderate trial. And we were also involved in some of the pre-trial, I was involved in some of the pre-trial qualification with in certain fetal balloons. And so we published some data in those patients, which I think actually offers some information that may help address some of the concerns or questions that Dr. Case brought up. I think one thing that's been clearly raised is the very low survival in the expectant group in Europe does not take into account the aggressive management for CDH that we do here in the US. We were able to actually experience that in our work initially while we're getting ready for qualification. And because again, we practice aggressive postnatal management with ECMO for all patients as available, very similar to what Dr. Case does. But what we actually noticed in that subgroup, again, limited number of patients, of course, was actually that with patients of equivalent severity, the need for ECMO in the patients that had tracheal balloon was actually less. And I think that probably reflects a lot in what we're seeing in the paper presented by Jan. And if you actually look at it, again, Jan may be able to comment, but probably, I don't know what the ECMO availability is in most of the centers. So the percentage of ECMO use may actually be more of a reflection of ECMO availability. And as we all know, many of these patients, if they're really unstable initially, we can bridge them on ECMO and actually get them to repair. So the repair rate goes up when you actually have ECMO as a backup to use. And I think that would affect the ultimate outcomes if ECMO is not even available in many of those centers. So it brings up the question that others have raised as to how will this translate to centers that have aggressive postnatal management. The other aspect of it that I think it's important to mention is the issue of prematurity, which has been raised by all. There's no question that FETO does add to increase the rate of prematurity in these patients, and we know the consequences of that in CDH. But one thing also that has changed over time is our willingness to actually put premature patients on ECMO. Back in the day, again, in fact, part of the timing of when the balloon removal was planned was 34 weeks, by which time, if they delivered afterwards, they'll be eligible for ECMO. We've gradually ratcheted that down in terms of age and size, such that gestational age now is more of a relative contraindication than an absolute contraindication. And with very effective hemostatic coagulation management, we found that they haven't suffered the same, there hasn't been as much or hardly any bleeding risk as had been feared initially with the premature group. So that's another aspect, that delivering early does not necessarily exclude you from ECMO, although realizing also that FETO, while it has a risk of prematurity, may actually remove ECMO from being needed completely, entirely. I think Francois brought it up briefly, but the second procedure to remove the balloon is one of the major contributors to that early delivery. And also any mechanism to actually avoid that would definitely help reduce or eliminate that aspect of it. In addition, one modification that we have done, of course, not part of the trial, was actually delaying that time of the second balloon removal to much later, again, allowing gestation to go on. But of course, that can only be done in a team that is available to react in case of an emergency, because every baby that goes into labor every fetus that goes into labor with the balloon in place is at risk. And so you must always have a team available to be able to do that before you can take that risk. But we found that by delaying that, we could actually delay that second procedure and the impact that had on prematurity as well. But there's no question that prematurity is a factor. Ronnie brought up some important things to consider. What are the things we can actually do to enhance even the effect of FETO? And I think a lot of work has been done. Rayan and his group have pioneered a lot of this as well, with other mechanisms to remodel the pulmonary vasculature in utero and to see how that can ultimately affect outcomes. Some data seems to suggest that FETO in and of itself may have some effect on pulmonary hypertension. Can this be enhanced by other medicinal options or therapies? I think time will tell in that regard. One thing we haven't talked about at all, that has taken a lot of our time, is even the moderate trial. Clearly, the moderate trial did not show benefit, but one thing that was clear with that also is those were being done much later in gestation. For those of us that have seen the natural history of lung malformations and the fluid production, which is what, again, a lot of the growth in diaphragmatic hernia is based on, we know that fluid production starts to trail off at about 26, 28 weeks. So putting the balloon that much later, there isn't really much inherent fluid production to actually help the growth and development of the lung that we assume. So presumably the lack of benefit seen with the moderate trial may not have existed if it was done earlier, where you could actually see the benefit of lung growth in that area. That's obviously not assessed by this study, and that's something yet to be seen. So I agree with Francois. I don't think this is a yes, no. I think this shows that we are on the track to something. As Dr. Case has rightly pointed out, every institution has to figure out what their baseline values are to see what ECMO is able to offer or what FETO is able to offer in that setting. But there's no question that this data in the particular setting of this study in which it was constructed showed the benefit that FETO may have, and the applicability of it just has to be clearly looked at for each institution and their program. Thanks for the opportunity to comment.
Thank you, Yinka, very much. I'd like to ask Dr. Cass to chip in.
Thanks very much, Ronnie. It's awesome to be part of this amazing group of folks that have been studying diaphragmatic hernia for so long. And I'd love to start by congratulating Jan and the core group of his team that pulled off these two amazing trials with a lot of opposition that goes back from the beginning. And he persevered and is rightfully rewarded. I think that the severe trial does prove an effect of FETO in a defined population of patients with diaphragmatic hernia. The outcome from the randomized portion of the trial matches the historical data that Jan had published with much higher numbers of patients that were offered FETO. And Dr. Kays pointed out some of the concerns, I guess other folks that take care of patients with diaphragmatic hernia have, the low rate of use of ECMO, the low rate of repair. And I think, the question is how we define a population of severe CDH, and does the results from the FETO trial in Europe, which there were some North American centers, but majority of patients were in Europe. The question is, how will that apply to North America populations or US populations? I am impressed. I'm not sure of the patch rate of those that had repair in the published series here, but I'm aware that in Jan's older publications that have many more FETO patients, that I believe there were about 20% of patients that received FETO got primary repairs of their diaphragm hernia. And I think most of us surgeons would believe that a patient that can achieve a primary repair of CDH, usually those have very little liver up, and those are probably not what we think is a severe population of patients. I'm currently at the Cleveland Clinic, but I was Yinka's partner for 18 years in Texas and at Texas Children's Hospital, and we published a bunch on this. And I'm aware that when we looked at predictors of severe, ultrasound-based predictors were not as robust as MRI-based predictors in terms of calculating the lung volumes and the fraction of liver up, at least at that center with hundreds of patients studied. So I think how we define this population of severe is up, I think is a question for the future, and how we're going to apply FETO in other populations. But I do think that the severe trial did prove a biological effect. And that matches a previous prospective randomized trial that was done in Sao Paulo, Brazil, proving an effect in that population of patients. And so in Baylor, there were a couple of publications of a population of 10 FETO patients, and then there was a follow-up of 16 plus, and I'm aware of 20 plus patients that had FETO. And when we risk stratified those against specific fetal predictors of outcome, not just lung to head ratio, but also MRI parameters, we found a significant biological effect. And in that population of patients that had FETO, it was 100, they were all C and D lesions, most were D, diaphragmatic defects, they all had huge patches, but we were able to reduce pulmonary hypertension, reduce ECMO utilization, and improve survival. But again, that was not randomized data. But this is an amazing odyssey that Jan has led. Mike Harrison started. There were other contributors, but Jan has absolutely led.
Thanks, Daryl. So Jan, I think we kind of touched on a number of things, and I'd like you to give you the opportunity to kind of respond to some of that.
Thank you all, and I will try to be short on this very long series of arguments and questions. So number one, since this is prenatal management, we have to select patients, and we do indeed still do it in the most primitive way you can think of, is by measuring the organ that we think size-wise will predict the outcome. So I am sure that it will be, it can be better than we do now, 2-dimensional ultrasound, 3-dimensional MRI. I'm sure it can be done better. But unfortunately, we have no data yet to prove that it is so. But the defect size, this is a comment there to the patch rate. The patch rate is sometimes post factum used to judge on the severity of the population. I mean, this is I think this is not a very valuable argument. I mean, the patch rate, it was 70 to 90% in the two trials together. So that is not 100%, but it is not that low that I think it can be used as an argument that people would have improperly selected patients. As you know, you can measure the defect size, but there have been no correlations made to survival. What is much more interesting, of course, is the biology of this, this technique. Do the data support that? When we are now looking at the combined trials, we actually looked at the lung response. This was a secondary outcome measure. And the lung response was measured in this trial only in the FETO groups because the other patients didn't have serial scans. And what we saw is that in the severe trial, as well as in the moderate trial, there was increase in lung size. And that the increase in lung size was different in the severe than in the moderate trial. You really have to read between the lines to know that. And this was not on purpose, by the way. But so it shows that what Yinka said, that the response is different depending on the time point. I cannot disclose yet the details of it, but one of your famous journals in our field is now considering a paper that looks at the combined data and that goes into this issue of whether the time point of the occlusion plays a role in the pulmonary response with the outcome measures that we used, which is survival. And the answer to that is yes, the time point is actually more important than we guessed ahead of time for this trial. But I think the more interesting thing and I know assume here that in the USA, all centers have very high survival rates, whatever the severity it is. I think you will have then a very difficult task because you will have to power, if you would consider FETO, on an indicator that you select to be better or more relevant, clinically relevant than survival rate. I foresee two problems with that. It is logic to say we should design a trial based on morbidity. Well, I think you first will have to get an agreement on what you think is the most important morbidity indicator. Number two, you will have to be sure that that morbidity indicator is modulated mostly by the prenatal intervention, but most of the morbidity indicators that I know of, many of them are related to the postnatal management as well, not necessarily the way it is managed only, but also all kinds of postnatal events that mix in diaphragmatic hernia and that cause other morbidities that are not related to the prenatal thing. But then the worst is still to come. You will need a way to select patients based on that morbidity. And there I can only say, after 20 years, even more frustrated than with prematurity, we are extremely bad in predicting morbidity in diaphragmatic hernia. Anything longer than 48 hours of life, we get lost. And I think that is partly because many of these things are postnatal events, modulated by what we do and a mix of prenatal things that we cannot measure. So that is a difficulty where I will invite you to solve it, because we're still looking at mortality. Coming back to the questions of when we assume there is a biological effect and that we assume that there is an increase in survival, how can we make it better? A small comment on that second intervention. There are two misconceptions here. Number one is that the second intervention is the main cause of prematurity. This is not true. It's the first intervention that is the main cause of severe prematurity. Many of these things happen before the second intervention happens. The second intervention is really not a pleasant thing to do, not for the mother, but certainly also for the surgical team, not only for availability, but also for technical reasons. So it would be good if we could avoid the second intervention, but the answer is already there. In 2 weeks, we start the phase 1 trial with a reversible balloon. In Paris, already such a balloon in the phase 1 trial has already been inserted. So within 2 years, we expect to be able to say whether this is a safe and effective balloon, or safe balloon, let's put it that way. I am very optimistic as to your regulator, the FDA, how they have changed over the last 10 years. They will, if they find this relevant as an improvement, they will look into it with you, how they can allow this device to be used, because your FDA really is now very constructive when they look at those things. And I think we should take that opportunity, because they really are. One of the nicest emails I had after the trial was from a person from the FDA who was thanking me for having explained very well a few years ago how this balloon worked, and that she says, no, at least it was not in vain. But then let's see whether we can do something else. Can we reduce prematurity more? The bad news is that the industry will probably not follow us. One of the manufacturers of fetoscopic instruments has now has decided not to look further into miniaturizing the scope even further. That is unpleasant news, but this is the consequence of the current MDR regulation. Can we do something more to power the biology of the occlusion? Yes, I think so. Changing the time point, but also adding things, adding drugs. I mean, we are looking into the administration of vesicles, which at least in animal models work. I mean, I'm sure we can do better, but within 1 or 2 years, we will at least have solved that problem of the reversal. And so I am quite optimistic that at least if we use this trial as a reference, that we will improve a bit on prematurity, that we can improve on increasing survival in the moderate trial by reconsidering the time point. But the big breakthrough for you is appropriate methods that are powerful in predicting the morbidity indicator that you have selected. I am not sure that we can solve that for you from the prenatal side, but again, there is a new generation to come that can do better than what this generation has done. I hope this is a bit of an answer to everybody.
Thank you, Jan. This has been great. So I think the future is bright. I think we look at this as a springboard, that we were, as a team, able to successfully design, implement, conduct the trial, and then finally now we have results. Obviously, you know, this is not the end. It should be viewed as an invitation to pursue further innovations and interventions. I'm thankful for all the participants, and I would like to ask if there are any other comments related to the discussion. I think everybody's muted.
Sure. How is that balloon going to reverse?
Okay, I will summarize the work. This is a invention of Dr. Sananes, who used to work in Houston, to his credit. And so it is a magnetic valve, And so it basically, when the patient is exposed to a strong magnetic field, the valve opens, the balloon deflates and finds its own way into the gut or into the amniotic fluid. We have proven not only safety, but also efficacy. And we are now allowed, at least in Belgium and in France, to use this balloon in twice 28 patients, and where the endpoint is that it can be reversed non-invasively.
I have a quick question, a comment on what Jan said, if you don't mind. I think for many years, and I would agree with the position of the FDA, where they've been maligned for many years because they supposedly stifled progress, especially in things like fetal surgery or pediatric surgery in general. I think that you're right. The FDA is not necessarily a hurdle who can work with us. I think that the industry and the economic forces are much more of a problem. Again, it was really nice to see that for the myelomeningocele and open fetal surgery proposition, that we as a group, large consortium, were able to work with the industry, but that is a problem. Orphan diseases and orphan treatments, we need to rely on technology, and technology answers to economic forces as much as to clinical forces. And so that's where we need to direct our efforts, in my opinion.
Can I add a little bit to that? I mean, indeed, the industry is a limitation. I mean, of interest is the balloon is made by a minuscule French company that has to survive on a vascular occlusion device. And they will probably, I think they will never have the funds to bring this really to a big market. So we hope that at that stage, somebody is found that wants to invest in it. But also on the medical side, as you know, we have done a tremendous effort to try to bring sildenafil as an antenatal drug to a clinical trial. And now what you see is that the regulators, to our humble opinion, have misjudged the data currently available on the use of sildenafil for other indications, where our phase 1 trial was stopped for observations that were made in another context in babies without lung disease, but that have now completely stopped the use of sildenafil in pregnant women, either for fetal or neonatal purposes, as well as for maternal conditions. So we were stopped nearly when we were there, and we're now looking at another drug, but so also the regulators on the European side will have to be with us. So therefore, again, I'm so glad that the FDA now looks at things differently, and so please take advantage of that and help us on this side.
It's a very good point.
Wow, what a great session. To have heard a lecture from Dr. Jan de Prest reviewing results of these two published randomized controlled trials, investigating the role of FETO in the treatment of fetuses with diaphragmatic hernia, and then to have this lively debate with leaders in the field, Dr. Kevin Lowley, Dr. David Kays, and others, pointing out possible problems and possible differences in populations of patients. Obviously, there's lots more work to do, but I'm very excited about the future of our ability to improve the outcome of fetuses with diaphragmatic hernia. Next, I'm excited that we're going to have a live question and answer period. Members of our panel will be available to answer any questions you may have, and perhaps to answer questions from each other. I look forward to this. Thank you so much.
All right, we are now in the live session, the Q&A portion of our APSASode, and we have a question from Dr. Muratori. Basically, if we know that based on the trial, we see that there is a benefit to FETO in the severe group, is there any way that we can look at a biological response if there is more lung tissue present with a response to FETO compared to just better postnatal care.
Can we confirm that there are other members from the people viewing that have joined us also?
Right now,
There are
it's
33
just us,
people
I think.
watching.
Okay, cool.
So Yinka and Francois, what do you think? Is there a way to say maybe the response that we're seeing in the severe group after FETO is related to that they started off with more lung tissue, therefore better response?
Can I just quickly? I don't want to read into Chris's mind, but I think what he may have said is that historically we know that with FETO, at least early on, some of the worst outcomes were when there was very, very little lung present, so LHR of below 0.5. And so, which was very disappointing. It was kind of like the liver up with open repair, where it was the worst outcome was for those who needed it the most. So I think what he was asking was that in the moderate trial where you have decent enough lungs, how come there is no better response with FETO? And I think one of the reasons might be is that because the postnatal outcomes are so much better, as David showed, obviously with this superb series, it's harder to show a benefit. And of course, any benefit that you may have could be mitigated by the fact that you have more prematurity.
I think that's a great point. And as we discussed in the pre-recorded session, with the moderate trial, if you're starting the occlusion much later in gestation, we know that lung fluid production at that stage is already quite late. In fact, some have advocated that potentially even for those with the very, very severe forms of pulmonary hyperplasia or severe forms of diaphragmatic and enhanced pulmonary hyperplasia should even be done earlier. Of course, you're trading prematurity for earlier lung growth. Now, the question is, would you have sufficient lung growth such that the outcomes you have would even be better? If you even just go back to the Mike Harrison trial way back when, we found that those, even in that trial, those that had tracheal occlusion that were born much more premature had outcomes almost similar to those that didn't, that were born later. So while prematurity was a confounding factor, there was sufficient lung growth that kind of made up for it. And I think if you look at the single center study that we did back in Houston at Baylor, you could find that those, with comparable groups with the same level of aggressive postnatal management, there definitely seems to be some benefit with FETO. But I agree, I think the time when you place the balloon has to take into consideration the natural history of lung fluid production. If you're doing it much later when the lung fluid production is tailing off, you're not likely to get as much of an impact. And that's what I think we're seeing with the moderate trial. And so presumably, if we can solve out the issues of prematurity or be more confident in our outcomes with that, I think the benefits of going earlier would show itself.
Yeah, can I at least politely make sure that we're communicating not the same message here? I would not remotely support the idea that we're going to go earlier intervention on moderate CDH. I don't think we're ignoring the fact that the control survival group in this study was very, very different than what we're seeing in North America. And the non-surgical rate was very, very high. And so we're going down the path of all things wonderful FETO, but we've got to be very careful. And thinking about earlier intervention for a moderate group who in North American experience has a very good survival, I think is very unwise.
Can I make a quick comment on Yinka's point of view? I mean, regardless of whether we should and the differences between North America and Europe. On the other hand, going earlier, certainly in animal models, we showed that going earlier when the lungs are more immature, the response of accelerated lung growth may actually be dampened. So there may be an advantage in waiting, just from a scientific standpoint, there may be an advantage in waiting longer, waiting later until you have more mature lung tissue to work with. But of course, this is purely theoretical.
I wonder, can I ask a question of David? Because David gave a great a great argument about some of the complexities of the trial that was designed, but he said a provocative statement, and that is that he achieves greater than 90% survival in a population that he defines as severe. And I do think there's opportunity for uniformity in how we define things, but my question for David is what population is he defining as severe? And is that based on prenatal risk stratification or the postnatal scoring systems? And how do you define that?
Sure, thanks, Daryl. For the purposes of that discussion, I was defining it the same way it was in the FETO trial, and that was an LHR ODE of less than 25%. All of those kids, all of those kids are also liver up. But
thank you.
Sure.
I think there was another question by Dr. Blakely, which I think taps into, what we were just talking about in the comment made by Dr. Lally and Francois going earlier in these moderate babies. But I think this is from a statistical standpoint, there is the confidence intervals are going towards benefit in the FETO cases. And obviously we all kind of go into that discussion about, biological relevance versus statistical significance. And the question is here, is the p-value here of any relevance? And I would also echo the same comments and make sure that in this particular scenario, because we're dealing with two patients, the mom and the fetus, that we can't really ignore that. And I think that is just something that there's a difference between talking about a postnatal care of these babies versus prenatal intervention when we both have mom and baby to deal with. Any other comments about that?
Yeah, so I'm clearly not nearly as good a statistician as Martin Blakely is, and I don't want to guess what he really meant, but I think he's right. If there seems to be a trend towards improvement, why do we really need a p-value below 0.05? But I think this would definitely be true if the risk was negligible for the mom and for the baby, which it isn't. So I think, we've seen it with a moderate trial that there was an increased prematurity, and so we have to be very careful. If we ever reach a point where it is negligible, the complications for mother and or child, then we can start talking about incremental improvement. Otherwise, I think it'd be really hard to justify.
Yeah. Also, there is Aaron Perron is posted that don't we have to look at long-term morbidity outcomes as opposed to only survival in ECMO? And I think we in our pre-recorded session, we started introducing the concept of is a survival as a primary endpoint, a primary outcome, the only way to design such a big trial? And should we start looking at a composite of morbidity, which is difficult because we all have these heterogeneous population of patients and approaches to their care, which would complicate how would we define these certain aspects of morbidities. But I would like to ask Dr. Lally and Dr. Kays, if we were to agree as a group, can we come together and say, these are the morbidity outcomes that we would consider for a trial, whether it is another big international trial or even a US-based trial?
Yeah, it's going to be very difficult, as I think Jan was alluding to as well. And the problem is one is weighting the composite variable, is what degree of neurologic deficit is good versus bad, what kind of feeding episodes are good, bad. So making these composite variables is extremely difficult, and getting national or international agreement on definitions, that would be unique if we could do that. So anyway, very, very difficult. And Dr. Blakely, if he's still on, he was the lead on the NEC trial, and that took 15 years and so a trial like this would just be a very, very difficult to achieve.
Yeah, Kevin, to add to what you had to say, You know, the number of kids we save, and I mean we as a community, is really about how well we take care of their lungs. But the quality of that survival is really about how we take care of their brains, and the brains are really the most important outcomes and hard to measure. At our institution, we do an MRI on every kid that goes home. Obviously, connecting the anatomy, the anatomic brain to function is an imperfect kind of a relationship, but obviously feeding issues and need for oxygen is not that big of a deal. Feeding issues we all struggle with. I think there's a lot of progress that can be made on those, but how they do 2, 3, and 4 years later is really, I think, mostly about how their brain survived everything we did.
Can I just quickly say, to be completely fair to the FETO trial and to Jan, the mother trial tried to do exactly that, because Marty Blakely mentioned the survival advantage. It wasn't about that. It was about a composite, trying to find a composite outcome measure that can say that it's not going to be much difference in survival in the mother trial, but can we mitigate the complications? And their proxy was oxygen at 6 months, which is a very vague and then low bar, but at least they tried to do that.
There is a basic science kind of translational question posted is there anyone researching fetoscopic local delivery of growth factors or stem cells or magic juice by Doug Miniati to encourage the prenatal lung growth? Yenka and Francois, comments?
I'll let Francois go first on this one.
I was just going to say, I would let Ronnie go first, because I think, Ronnie, you've been working on that. So why don't you tell us a little bit about your research?
Yeah, so, you know, we started looking at some of delivery approaches to these, and in the rabbit model, which was based on previous work by Francois and Monique, which was wonderful. And basically, the idea was not only to promote lung growth as a response to the lung fluid secretion, but kick in a pulmonary vascular response to that. You know, the issues are obviously which magical juice that you want to use and what form of delivery. We use these slow release osmotic pumps in the rabbit model. And what I can tell you is we've seen some changes in the vascular response as far as histologically looking at the vessels, but I am unaware of any other research groups who have published a mix of growth factors or stem cells. I know that Jan's group is also looking at potentially using some of the combination of phosphodiesterase inhibitors to help with pulmonary vascular response. But there is nothing out there that I'm aware of.
And a quick clarification to Doug Mignati's question, I don't think we need to simulate lung growth. Tracheal occlusion is incredibly good at simulating lung growth. The big problem is pulmonary vasculature and pulmonary hypertension. So that's the frustrating part, is in almost all cases, you see massive growth of the lungs. That's not the problem. The problem is postnatal pulmonary hypertension.
You know, the only really good research that was out there, and unfortunately this was stopped by the kind of European FDA, Jan started looking at the use of sildenafil in the animal models with tracheal occlusion. And the problem was they looked at all the potential side effects in not related to what the research question was, and that became a moratorium on its use. So I think now there's a shift to, instead of trying to use sildenafil, is to use other modulators that would promote pulmonary vascular growth.
I think there's some evidence that there's improvement in vascular development under FETO. There's some reasonably good data that suggests that pulmonary hypertension is decreased in that population. And I bet Jan can come out with future data about that. But that must be that there's some improvement in oxygen delivery into capillaries. And I guess that means there must be a better capillary network to have decreased pulmonary vascular resistance.
There was tremendous proof of that in animal studies. That was a frustrating part, is thinking in several animal models, we and others showed that you had a remarkable pulmonary vascular response. The problem is those are all non-natural occurring diaphragmatic hernia cases. And so it's not the same in humans. And that's the frustrating part.
And that's a great point, Francois, as you know, too. I mean, even in the clinical experience, why tremendous lung growth has been shown in animal models, that hasn't always held true for every fetal human patient. So some grow well, some don't, and still trying to understand which ones don't. Is it a technical issue with incomplete occlusion, or is there something inherent in this particular lungs, or are there some genomic genetic aspects that can be further understood? I think is still in question, but clearly I think there's still room to improve. Lung growth is pretty decent with tracheal occlusion. Then, I mean, it's not as big a problem as the vascular malformations, and anything that can help improve those would potentially be helpful. The challenge is, how can you help Dr. Case already has greater than 90% outcomes? I mean, is it going to be feasible? Is it even going to be effective or needed in that setting?
Another way to word it might be, I believe that Jan has proven that there's a biological impact to FETO in fetuses with diaphragmatic hernia. But the question is, who should that be applied to? How do we select that population of patients? And David is challenging that in his population of patients, perhaps it isn't worth the risk to put the mom through a FETO intervention.
Right, especially if we don't come up with a better way to eliminate that second procedure for balloon retrieval, or all of a sudden now, going back to Francois' presentation, if we can really minimize the risk of rupture of membranes and prematurity and take that out of the equation and add on top of that a better response, not from a pulmonary parenchymal growth, but vascular growth, then that makes the discussion and the debate a little bit different than the obvious risks that we currently have with the FETO.
Or when David retires and the knowledge of getting 90% survival disappears.
That too.
All right. Our goal is to show what the potential of these kids is, with a strong focus on the postnatal management. The things we're doing aren't a secret to anybody. It's really good care of lungs. It's getting surgical repair done in a timely fashion. It's upping our game with ECMO, where the survival with ECMO can be significantly improved by improving our techniques and our focus on those things, and having a cohesive plan that is consistent throughout the care. And we will be publishing our data soon and look forward to people's impressions. But what we're doing is just focusing on getting it right every day and seeing if we do that, how high can survival be? And we're going to continue that focus. And we hope, I think it's important to note that what's being discussed today with FETO and what we're focusing on in postnatal management are complementary things. We're all looking at this, trying to improve the care of these patients. And again, I congratulate Francois on his great accomplishment, and not to take anything away from it, we're going to keep focusing on the things that we're doing.
And I'm sorry that you called Jan my name, but that's okay. I'll take the compliment.
Oh, I'm sorry. I said Francois at the end, didn't I? Yeah, I'm sorry.
So I expected that question, and I'm glad that question was posted. Doug Maniati was saying, well, severe CDH seems like a disease that could benefit from the CHOP baby in a bag, plus or minus TO. Any comments on that?
Long way off.
theoretically it makes sense because then you wouldn't have to worry about premature delivery, right? You could get all the benefits of the challenges of preterm delivery. I mean, so in theoretical aspects of it, if you have a fetus with diaphragmatic hernia, we all know part of the challenges with this fetus is ventilating premature lungs that with the barotrauma that ensues, and that's why Dr. K's approaches with rest and growth and development of the lungs on ECMO are quite feasible again to have that postnatal growth. So this is a matter of how can you accomplish lung growth. Back in the day was liquid ventilation, is it tracheal occlusion, or is it postnatal long-term ECMO? If you can keep the lungs growing and developing without the baby suffering untoward consequences while that is happening, I think that's possible. I agree with Dr. Lally. Of course, the extend model is still not quite ready for prime time, but you could see how if you had a preterm baby with diaphragmatic hernia that delivered preterm for whatever reason, I mean, those two technologies combined could have potential benefit, but it's not ready for prime time yet.
All right. Well, I thank you all for a wonderful session and for being available to take these questions. I believe we don't have any more questions in the live chat, so.
No, but Salim made a comment, I think, which is important. Apparently, the knowledge will not disappear with David K's retirement because they've been able to continue the same track record, so that's great.
Propagate the knowledge. All right. So again, thank you all for participating and for a very wonderful session and a live debate, as well as the discussion of these questions. And have a good night.
Thank you.
Thank you.